Hi, everyone. I'd like to extend a warm welcome to all of you and thank you for joining us today to talk about Black families and cancer awareness, engaging the generations to reduce healthcare disparity. This webinar is the first of our SIO Summer Wellness Wednesday series. There'll be 5 more webinars this summer, and our theme this year is Health Equity, amplifying the voice of the underrepresented in cancer care. My name is Lee Leibel, and I am the host for today's show. As we saw in our opening video, music and storytelling are powerful ways to communicate and create awareness around the important issues that are facing our society. As we come together today for this important conversation on Black families and cancer awareness, it's important to recognize that disparity in public health is not just an issue of poverty or socioeconomics, it's also one of equity and social justice. So in this video, we wanted to present the staggering cancer statistics within the context of what is going on in American society today. And we're going to explore this in our next hour together. We have a rich program for you today and presentations from 4 expert speakers. Lots to unpack. So let's get started. If you would please mute your microphones if they're not, and put your questions and comments into the chat. The last 10 minutes of our show, we really want to hear from you, and we will be taking questions. So now, if Molly will please bring up the speaker photos, I will introduce all 4 speakers at once, and then I'll turn it over to our first speaker to get us started. So it's my pleasure to introduce Dr. Eleanor Walker, Senior Staff Physician at Henry Ford Cancer Institute in Detroit, Michigan, and Division Director of the Breast Services in the Department of Radiation Oncology, and Medical Director of the Henry Ford Health System Center for Integrative Medicine. Her clinical interests include breast, prostate, radiosurgery, and cancer incidence, as well as the treatment of minority populations, especially breast cancer and integrative therapies. Dr. Walker serves on the Board of Trustees for the Society for Integrative Oncology, and she is the co-chair of the Health Equity, Inclusion, and Belonging Task Force. Our second speaker, Dr. Santoshi Narayanan, is Assistant Professor in the Department of Palliative, Rehabilitative, and Integrative Medicine at the University of Texas MD Anderson Cancer Center in Houston. Dr. Narayanan joined MD Anderson in 2015 after serving in both private practice and academic medicine. She practices integrative medicine, and her research interests include mind-body techniques and yoga in the care of cancer patients. Our third speaker is Dr. Darlingtina Essiaka, a visiting professor in psychology at Union College in Schenectady, New York. She is also the lab manager and principal investigator of the laboratory called Health and Aging from Minority Perspective Lab, or HUMP Lab, whose research revolves around social determinants of health and the life course, and the cultural groundings for the experience of relationality. Dr. Essiaka is a member of the SIO Health Equity, Inclusion, and Belonging Task Force, and also the SIO Global Task Force. And our final speaker today, Mr. Melvin Mann, is a national health and wellness patient advocate. Mr. Mann was diagnosed 26 years ago with leukemia and given 3 years to live unless a bone marrow donor could be found. They were unable to find a life-saving marrow donor despite conducting numerous marrow drives and adding thousands of people to the marrow registry. He entered phase 1 of the Gleevec clinical trial back in 1998. Gleevec is a targeted therapy, and he is now the world's longest living Gleevec survivor. He is a member of the SIO Health Equity, Inclusion, and Belonging Task Force. So with no further ado, I am going to hand the presentation over to Dr. Eleanor Walker, who is going to tell us about the importance of screening and early detection. Dr. Walker, take it away. And you're muted. You're muted. Dr. Walker, you're still, there you go. There you go.
Excuse me, I'm trying to get back to where I need to be for you guys. So bear with me a moment. My screen went crazy here. And I'm not getting back to where I need to be. Hold on one moment. Very sorry about this. This is what happens nowadays with, okay, let's see if I can get this to do what it needs to do here.
No problem, Dr. Walker.
This is just great. We just had it working too.
Yeah.
Let's see. Okay, so that's there. Now I don't see where I can share with you guys again.
Morgan, can you maybe jump in and?
Of course, Dr. Walker, we actually can see your PowerPoint. We can see all of the slides. So
Okay.
if you can locate the PowerPoint maybe in one of your tabs. Oh, there we go. I see your mouse. So
Okay.
you can go to, yeah, go ahead, click that.
All right, now we got it.
And then we're going to want to do the display settings that we discussed.
Okay, did that again, huh? Better?
Perfect.
Okay, so then I have to shrink you guys because I'm seeing all of you. And I need to get out of that too, but I'm just going to put you like this, so excuse me. Okay, hello everyone, bear with me. I'm sure all of you have had this issue, and I'd like to thank SIO and the Yoga SIG for inviting me to speak for Wellness Wednesday, and I will try to speak, get through my slides quickly so that you can hear from the other speakers and ask questions. As we know, it's Black Family Cancer Awareness Week, and it's very important to engage the generations because we need to reduce health disparities, especially in underserved populations in this country. So I have no disclosures. So let me first share with you some stats from the US Census Bureau. By the year 2043, the so-called minority populations, which comprise about 35% of our population, are projected to become the majority. Sorry, it was a typo here. By 2060, those underserved populations, meaning those who are not of white European descent, will comprise 57% of the population. And by that same year, 1 in 3 Americans will be Hispanic or Latinx, as we tend to use today. And that means that will be about 100 and almost 29 million people. The percentage of Black Americans also will increase to 14.7% by 2060, and Asian Americans will double in population by that same time. Women are just over 50% of the US population. As we know, unlike African countries, the US population is aging. So by 2060, the number of Americans over the age of 65 is expected to double to 92 million. And those who are 85 years of age and older will make up about 4.3% of the overall population. And by the year 2040, women age 85 and over will make up the majority of the population of the world. So women rule the world, girls rule the world, as we know. And the number of international immigrants is expected to grow by 41.2 million in this country. So why is that important? Well, in this country, the 10 leading causes of cancer include number 1, heart disease, but cancer is number 2. And if we have disparities in cancer outcomes and cancer care, that's very important. Number 3 in this country has for many years been unintentional injuries. But it's important to know, that as of last year, COVID became the 3rd leading cause of cancer. And again, disparities in outcome. So cancer is the second leading cause of death among African Americans. And the 5-year overall survival rate is 68%. Now that may sound low, but it actually isn't. And I'll show you in the next slide. 1 in every 4 deaths is due to cancer in the US. And this year it is estimated that 1.9 million new cancer cases will be diagnosed, and just over 600,000 individuals will die from cancer. That is about the same as how many people have died of COVID this year. So in this slide, we see cancer death rates actually have been decreasing from 1975 to the mid-2000s. And that's in both sexes. And men have had actually a greater decrease in cancer death than women, but both have occurred over this last decade. We know, unfortunately, that African Americans are more likely to develop certain cancers than persons of other racial or ethnic groups, and have a higher mortality, both in males and females. And I keep saying the word disparity. What is that? Cancer disparities are cancers that occur disproportionately and affect underrepresented minorities or the medically underserved. So here are some numbers, and this table is from the NCI, but I want to start at the top here. Black women in this country had a lower incidence of breast cancer until 2015, but have always had a higher breast cancer mortality rate, and unfortunately that has not changed. Triple negative breast cancer, meaning that it is a cancer that does not grow in the presence of the female hormones or expresses the HER2 protein, which is a marker of a more aggressive cancer, is particularly common in African American women. And studies have shown that this type of cancer is associated with a decreased overall survival. Now, this is again important because where we see the highest number of triple negative breast cancer is in Africa. Sub-Saharan Africa. And so we know that the incidence in this country and even in South America and in England, where we see higher numbers of this, is related to the Middle Passage and the slave trade. Black women, breast cancer patients have more cancer recurrences and progression. Black Americans are 40% more likely to die of colorectal cancer. And the racial disparities in colorectal cancer deaths can be explained by differences in use, availability, quality of screening, and treatment services. Prostate cancer mortality rate is now 2.4 times higher among African Americans compared with Caucasians. But disparities is not just seen in African Americans, and this table shows you with kidney, liver cancer, and cervical cancer, other ethnic groups. And multiple myeloma is another cancer that of the bone marrow that we see predominantly in African Americans. So what are risk factors associated with cancer disparities? Some can be genetic and biologic, but a lot of it also has to do with healthcare access and underserved populations having less access and or less utilization of screening services and treatment, which is why it's important to know your history and know things that you should be doing, seeing your primary care regularly to get screened. Socioeconomic factors, chemical and physical exposure, diet, and physical activity. And our speakers a little bit later will be talking more about this. There have been some associations between genetic ancestry, as I was just talking about a little bit with triple negative breast cancer, and biomedical phenotypes such as lung function and breast cancer risk. But the association between African ancestry and lung cancer has not been shown. What a 2018 study has shown is that stage and treatment are more important predictors of survival. So we have to make sure that we're being screened so that we get diagnosed early and get treated early. There can be significant disparities in incidence and outcomes which characterize the disease manifestation among ethnically and racially diverse populations. One of our speakers will be talking more about the social determinants of health, which really does affect how people, when people get diagnosed, what kind of treatment they get, and access. So I'll leave that to our later speaker to talk more about. But the good thing to know is that cancer treatment in the 21st century is what we call multimodality, and really heading towards molecularly based treatment, precision medicine. Treatment depends on the stage at diagnosis, and what we call tissue agnostic therapies, where we're treating patients on the basis of the tumor's genetics rather than its location. And we have a lot of targeted treatments, immunotherapy that work in conjunction for chemo, for lung cancer, and what we call PARP inhibitors for breast cancer. So the good news is cancer is survivable if detected early, and the American Cancer Society estimates that some of all cancers can be prevented by lifestyle changes and early detection, which you will hear about lifestyle changes in a few minutes. Now, cancer can present many different ways. You can have no symptoms, or you can have any of these symptoms that you see listed here as a lump, bleeding, weight changes, sores, change in bowel habits, fatigue, tiredness. Now, with breast cancer being the most common malignancy worldwide in women, it's important that it's detected early, and we are blessed in this country that everyone should have access to a mammogram, and starting at age 40, especially in women of African ancestry, you should get your first mammogram. Unless you've had a family history, then you should get it 5 years before the age of the youngest person who had it, because it's curable with 97% survival rates when it's found early. And this again is listing some of the risk factors: age, family history, if you've had one before, when you started or stopped your periods, pregnancy, hormone replacement use, and race. So this is just the American Cancer Society's recommendation, which I just told you here earlier. Prostate cancer. Well, the incidence varies across the world, reflecting disparate genetic factors, diet, and other environmental factors. But it's important to know that it is estimated that 1/3 of cases of prostate cancer can be prevented, and another third can be cured if detected early. So it's the most frequently diagnosed cancer in Black men in this country, and the second leading cause of death. And so it's important to know what your risk factors are. Most men are diagnosed between 50 and 74, but we know if you're of African ancestry, Black men tend to get it at an earlier age, in their 40s. If you have a family history, you're not eating a healthy diet, all of these can be related. Early detection is through digital rectal exam, beginning at age 40, but the most common thing is a blood test, and then if it comes back positive, you discuss with your physician about a digital rectal exam and transurethral ultrasound for diagnosis. But we know in this community, nobody wants to talk about prostate cancer. They don't want to have a digital rectal exam. We delay screening because we're afraid. Men are afraid that they're going to lose their virility. People will use traditional medicine to try and lower their PSA if they know it's high. But it's important, because the very thing you're afraid of can be stopped if you get screened and talk to your doctor. And you set the example for your family by doing it also. Now, lung cancer is very common, and it's the leading cause of death in men and women in this country. And outcomes are best when you have a localized disease. We know smoking is a ¡1 risk factor for this. And depending on when you get diagnosed in your stage, that's when you can have a better prognosis. So, unfortunately for the Black community, we experience a disparity and poorer survival, as you can see here, than for white people in this country who are diagnosed, because we're more likely to be diagnosed at a later stage and are less likely to receive the recommended directed treatment. And the SEER data suggests that Black people can have a similar survival rate when you control for stage and economics. And also to receive stage appropriate treatment, meaning when you present to your doctor, do they do the genetic testing that's needed to give you the latest treatment, as Melvin will talk about later. And to have, for people who are at higher risk, to have the annual low dose CT scan of the chest, which allows us to find lung cancer in an earlier stage. Again, important to ask for that if you know you have the risk factors for lung cancer. And lastly, I'm going to talk a little bit about colorectal cancer. I think this has really come to the forefront. And in fact, guidelines have changed this year because of Chadwick Boseman being 39 years old when he got diagnosed with colorectal cancer and subsequently died of it. We know that men are more likely than women to develop the disease and die. And again, Black people have a higher incidence and mortality rate. It has always been considered a disease of the elderly, but now we're seeing it in younger and younger people. And so it's gotten such that the American College of Gastroenterology has now suggested that screening in average risk patients begin at age 45 to 49 years of age. That's a conditional recommendation, and screening definitely in people 50 to 75. What are risk factors? Age, race, hereditary. If you've had a history of intestinal polyps, inflammatory disease, diabetes, and again, the same theme, diet low in fiber, vegetables, and fruit consumption. Now, early detection includes a fecal occult blood test beginning at age 50, sigmoidoscopy, and colonoscopy. Now, I know nobody wants to get those colonoscopies. Nobody wants to clean out, but it's important and it can be done. So in summary, I just want to say, to reduce your cancer risk, stop smoking. Eat a diet rich in fiber, eat foods low in fat, limit alcohol consumption, be more physically active, maintain a healthy weight throughout life, get the HPV vaccine and the COVID vaccine, I'm going to say that, add that in, and see your physician regularly and get screened. It's important. Thank you very much.
Thank you so much, Dr. Walker, for that really, really informative presentation. Can everyone hear me? I seem to have some audio issues. Can you hear me? Just a thumbs up if you can. Okay, good, very good. All right, so next up, our second speaker is going to talk about ways to reduce risk and reduce the prevention and to prevent cancer through controllable lifestyle changes and modifications. So it's my pleasure to turn the program over to Dr. Narayanan, who is going to fill us in on all of that. Take it away. Thank you.
Can you all hear me?
Yes.
Good morning, almost good afternoon, everyone. It's my pleasure to be here and in this important topic to discuss about lifestyle factors. And I know Dr. Walker presented in detail about lifestyle factors and early detection. I'm going to reiterate some of that. So I'm going to get my slides to work, but until the slides open up, you can all, since my interest is mind body, I'm going to ask that you all relax, screen your body for any tension, and kind of let go and take big deep breaths at least 3 to 4 times. So we all kind of relax and think about what we can do. So it is clear from Dr. Walker's talk that there are lifestyle factors which is in our hands. There are genetic factors which causes cancer, which is not in our hands. But there is a significant amount of lifestyle modifications that we can do, and it is possible for us to do. It's not easy, but it's possible. And it's in our hands, and I think we should explore it further and do everything possible. So in fact, this is important for this talk today because it is unfortunate, but the fact is there is cancer disparity in the Black community. So we saw repeatedly from Dr. Proctor's presentation and the introduction video that Black Americans have highest death rate and shortest survival of most cancer in the US. Prostate cancer deaths are high, breast cancer deaths are high. There's increased chances of getting diagnosed late. So these are all CDC facts, and it is very unfortunate. So this becomes important because I want to highlight all the things that we can do. Everybody, especially important for Black Americans to do. When I say Black Americans, I mean everybody to prevent the causes of cancer, which are like prevent certain things which can cause cancer. So what are all these factors? So as previously pointed out, tobacco use, being overweight, diet, exposure to certain chemicals, alcohol, reproductive factors. So there are so many factors. So among these factors, the top three I want to highlight is diet, exercise, and obesity. And also stress management I will highlight because I really think that is an important factor, but not so much has been talked about it or done about it. So I will be stressing about that too. So first, thinking about obesity, as we know, is very common. So 7 in 10 Americans are currently overweight or obese, but only half of the Americans are even aware of the risk between obesity and cancer. So we know that obesity is associated with increased risk of many cancers. It's breast cancer, gallbladder, pancreas, ovary. You can see the dots in this picture all over the body, esophageal, liver, stomach, colorectal. And therefore, it's important that we take this under control. And you can look at this picture. This is among non-Hispanic Black adults, the prevalence of self-reported obesity. And this red color or maroon color represents more than 35%. So unless you live in Colorado or something like that, it looks like the incidence of obesity is very common. So it would be nice to move to Colorado, but I think it's easier if we just lose weight. So easier said than done, but it is possible with changes. Slow changes and making slow progress will make a huge difference in the long run. So one of the things that you can start changing or doing things better is nutrition. So again and again, research supports that eating more plant-based diet, eating more vegetables, eating more whole grains, eating less red meat is all geared towards cancer prevention. So as you can see in this picture, and if we consider that as our lunch plate or dinner plate, fill almost half of it with vegetables. And the red meat should be very, very small portion. And ideally, I tell my patients not to include red meat more than 2 times a week because red meat is associated with many cancers, especially with colon cancer. So the lesser the red meat, the better it is. And if you don't like to eat red meat, that's even great. You don't have to start including 2 times a week. It's just that if you're eating more than that, try to decrease it to 2 times a week. Lean animal proteins like chicken and fish are okay, but ideal protein comes from the plants. You can see the beans, lentils, nuts, and the carbohydrates ideally should come from the whole grains and eating fruit. And most people like to eat fruits rather than vegetables. I always tell my patients to eat more vegetables than fruits because fruits are rich in sugar also. So you want to eat fruits, but you want to eat more vegetables than fruits. And when I say that fruits are rich in sugar, you know what I'm going to say for sugar. So decrease the sugar intake as much as possible. So in terms of research, so this is not just something that I'm just making it up. This is shown in research. Vegetarian diet and incidence of cancer. Clearly, being more vegan or following a vegan diet is associated with a lower incidence. So I'm not asking you all to be a vegan. I'm just asking to eat more plant-based and less animal-based, which is more doable. And in terms of breast cancer recurrence and vegetable risk, again, high vegetable intake, lower recurrence risk. So research points out very clearly that we should all be eating more plant-based, and that brings to the importance of eating a variety of balanced foods in your diet with emphasis on more plant-based foods and vegetable intake. So the next important factor is exercise. So you can see that there's clear evidence pointing out that physical activity protects against colon, breast, and uterine cancer, all shown in research. So even simple things, if you can start walking 30 minutes every day for 5 days in a week and try to get 150 minutes per week, that will make a big difference for you. If you're able to add some resistance exercise like bands and weights, and if you can keep it in the desk. I keep the bands in the desk, so I actually demonstrate patients how to do resistance exercise. So that helps me get some resistance too. So you can keep those resistance bands in your desk if you're working, or you can carry it with them, and you can do it when when you get few minutes. So making it work in your schedule, trying to move your body and doing exercise is also very helpful for cancer prevention. And this resistance exercise, I suggest, will be like 20 minutes at least 2 times a week, so which is not a lot. So if you can get 150 minutes of walking per week, or any other similar activity like cycling or swimming or something like that. If it's vigorous, you can cut down the time. If it's not vigorous, try to keep 30 minutes 5 days in a week. And 2 days, if you can do the bands and things like that, that will make a huge difference in terms of cancer prevention. So sleep. Sleep seems like very small to think about, and it seems like more common sense. But clearly, sleep has an important role in our immune system. Sleep is when our body regenerates, repairs, our immune system gets better. And as you all know, our immune system is important for cancer prevention. So make your sleep a priority, your self-care and able to sleep and going to bed at the same time every night and maintaining like kind of a schedule and avoiding caffeine afternoon. Unless coffee don't bother you, you can sleep well. It's best to avoid it so you can sleep well, and establishing a conducive environment. So even simple things like sleeping well and focusing on it and being mindful of it will make a difference. So the other factor is stress. And I know especially during the pandemic time, a lot of people, both my patients and my colleagues and everybody I see, they have been like thinking about they need an easier job, a smaller house, and a different family, because it's like there's so much going on with all these pandemics, and it can be difficult. So these are not possible. It's if you cannot do all the three, and I think if you did that, it's still, the stress will be different kinds of stresses, but kind of the stress may be the same. So the best thing is to work on ourselves. So doing mind-body practices. So when I say mind-body practices, it's yoga, meditation, Tai Chi, Qigong, music therapy. And I know you might know some of these terms. Qigong may be new. So Tai Chi, you can see in the picture, they're doing Tai Chi in the park. Qigong is a modified version of Tai Chi, which is more gentle and people can do in a sitting posture, in their office or in the desk. So these are mind-body practices. Basically, when your mind is racing somewhere, that's not good for our body because our stress hormone levels go up. It's not good. So you want to bring your body and mind together and connect it. So when your mind is racing, you're bringing your body back to your breath as in meditation. Your posture as in yoga or Tai Chi, or sound as in music. So these kind of small things that you can do, like even 5 minutes on and off, can make a difference in terms of your stress management. So there is scientific evidence, even in cancer patients, that yoga helps in a lot of areas like quality of life, fatigue, stress, and cognitive function, and so many things. So where can you find these resources? Of course, we have a website at MD Anderson. So these are open for everybody. So you can just Google also. You can Google MD Anderson Integrative Medicine. I'm sure Memorial Sloan Kettering also has one. So you can go to their website too. So these are available as audio and video recordings, and you can listen to these and practice these, and it can help. So overall, early detection, Dr. Walker touched on it, and she mentioned about how important it is to detect cancer if you suspect that there is something going on. It's best not to postpone it, because I, as an integrative medicine practitioner, I've seen a lot of patients who do not get screened early, thinking that they want to explore natural methods, and sometimes they feel fatigued, they feel like there is some lump, but they don't want to go to the doctor. And actually, when they come back to us, the cancer is already advanced. If they had come earlier, the treatment would have been so much easier. With the one small surgery like lumpectomy, just take the lump off and they would be good. But when by the time they come, the cancer is already spread, so they have to go through chemo. So a lot of times those don't work, and I've seen a lot of things which is more distressful to people. So I highly suggest to have all the information. So when you come to your doctor, they're not going to ignore that those treatments don't work or something like that. But I think the most important aspect is to get detected, do the right thing, and then explore. If there's natural options you want to explore, you can always talk to integrative medicine doctors, and we will give you all the information, all the facts. But early detection is important. But what is more important is doing everything we can in our capacity. So being physically active, trying to maintain a healthy weight. It's okay if we are starting out at obese weight. We can get there. It's going to take time. We can get there. Eating more whole grains, avoiding refined carbohydrates or fast foods like fries and stuff like that. Reduce consumption of meat, reduce consumption of sugar, sodas, reduce alcoholic consumption, and there's no magic supplements. If we did everything wrong, and if there is a supplement that can prevent the cancer, trust me, I will be happy to leak that today. But there's nothing like that. So we have to do all these things and stay healthy, fit, active, and have a better quality of life and prevent cancer. So with that, I would like to end my talk, and thank you for having me today. And I wish you all a very healthy and cancer-free life. And thank you for listening, and thank you again for having me today.
Thank you so much for that beautiful presentation. We have several of the Yoga SIG members on the call today, so we all appreciate the importance of stress reduction and using the mind-body therapies. Thank you so much. All right, now we are going to hear from Dr. Darlingtina Essiaka, who is live on tape. And hopefully I can figure this out so there is actually audio on this tape. I do apologize. There was supposed to be audio on our opening. Well, there was audio on our opening, you just didn't hear it. So if you can, I'm going to play this. If you can just give me a thumbs up that you can hear it. I'll roll it now. No sound yet.
Thank you to SIO for the invitation to be part of this awesome panel. This is a very important topic for us to continue having for the Black community, and also an important step as we continue to recognize that health outcomes in communities of color is equally a social justice issue. So, important for furthering this discussion and furthering that recognition of health outcomes as a social justice issue is the recognition of the role of social determinants of health in exacerbating cancer health disparities, especially in Black communities. Social determinants of health are defined as social and economic conditions where people live, where people are born, where people learn, where people work, where people play, where people worship, and basically where people age out, that can affect a wide range of health, functioning, and quality of life outcomes and risk. The main 5 domains of social determinants of health are education, neighborhood and built environment, healthcare and healthcare access, economic instability, and social and community context. It is very and equally important that we take a step back and ask ourselves, what will cancer health equity, what will lifestyle changes, and what will mental health of those diagnosed with cancer or those who have survived cancer look like through a social determinants of health lens. I said this because given the historic and daily lived experiences of Black people in America and all over the world, it's important that we ask ourselves, what will cancer risk reduction, resilience, and survivorship look like for Black communities and Black families? How does the historic and even everyday experiences that Black families and communities have inform the experience of mental well-being among Black people diagnosed with cancer and those that survived cancer? In general, how easy will it be for people living in poorer social and economic conditions to adopt lifestyle changes and maintain mental well-being? To think of it in another way, how well does the lifestyle change that we are prescribing to Black people and Black families factor into their daily lived experiences and daily lived situations? For example, when we tell Black families to eat healthy to reduce their risk of cancer, do we know if they can afford to eat healthy? Mm. How many whole food stores are there in their neighborhoods? Do we know if they live on food deserts? Do we know if they are food insecure? And whole foods, unfortunately, are very expensive and a luxury for most people. And additionally, when we recognize that nutritious food has been linked to cancer management, cancer risk reduction, and even maintenance of well-being, then we begin to see the magnitude of the realization that recognizing social determinants of health is important in our fight against cancer. Also, when we tell people to adopt taking a walk around their neighborhoods, right? We need to be sure that they have a walkway. We need to be certain that this wonderful lifestyle change we're prescribing for them, they can actually take part in it. They can actually wake up, open their door, step out, and get a walkway that they can walk through to get that daily needed exercise that helps to reduce their risk and improve their chances of survivorship upon diagnosis with cancer. I guess what I'm saying is that recognizing social determinants of health in our fight against cancer helps to refocus our attention to upstream determinants of the lifestyle changes that we're prescribing, and also mental well-being as it concerns cancer risk reduction and survivorship in Black families and communities. So just promoting healthy choices won't counter cancer health disparities. Mm. It won't stop cancer health disparities, especially in Black families and communities. I am not saying that prescribing these life changes is not good. All I'm saying is that we need to take a step back and recognize that it is not a clear-cut case, right? Instead, in addition to prescribing all of these wonderful ideal health and lifestyle changing behaviors to people, all stakeholders must work together and take action to improve the conditions in people's environment that can then help them engage optimally and successfully in the lifestyle changes that we are prescribing for them. So before we recommend that lifestyle change, we must do our groundwork. We must do our homework to determine a more tailored lifestyle change that is suitable for the people we are targeting, to determine if what we are about presenting to them is suitable, it's sustainable, is even achievable given their social and economic conditions. If the target is to get them to eat right, we must first determine if they can buy right to be able to eat right. And if they cannot, then we must find a way to work with what they have, because that will be more sustainable than selling them a fairy tale of luxury food options or things that they can do but can not afford to do. We must find a way to work with them, work with the limited resources they have, work with the realization of their everyday lived experience to find a lifestyle change, to find optimal health behaviors that will work best for them. We must avoid silver bullet trap, because one size does not fit all and one size has never fit all. And this is literally one way to ensure that we promote equitable potential for health and well-being for all. This is one of the best ways that we can ensure that we promote equitable cancer health in Black communities, basically. And I would like to end with one of my favorite quotes. As we are preparing and prescribing all these wonderful lifestyle changes to Black families, to Black communities, it's important that we ask ourselves, why treat people and send them back to what makes them sick in the first place? Thank you for listening.
Thank you, Dr. Essiaka. So powerful, so powerful. Especially the idea of why treat our patients and then send them back to the cause of their ill health. Thank you for your presentation. Mr. Mann, you're up next. I'm going to toss it to you so that we can hear the patient perspective, bring a voice to the cancer problem.
Well, thank you so much. And this is good going last because I've talked for 1 minute and I've told my story for 30 minutes, so I can fit into this time frame. And it's great fitting in the other speakers and their point of view. And it all started 26 years ago when I was diagnosed with chronic myeloid leukemia, as was stated in the introduction. And I was in the Army. I was stationed in Michigan with my wife and my 5-year-old daughter. I was 37 years old at the time, and I had symptoms of back pain and fatigue. And I think those symptoms are very important because a lot of times we don't pay attention to symptoms and we don't get in early to to see the doctor. So listen to your body. I've been experiencing those symptoms for 6 months, and eventually the doctor ordered the MRI, and my diagnosis was made from that. And he could have just took a simple blood test to find out that I had leukemia. So he came back. He said the only cure was a bone marrow transplant. And my sister, who was related, my best chance, she did not match. So being African American, I looked on the registry, and he had said, the chance is not very good. And this was 1995. And the previous year, only 1% of African Americans filed a donor. And 2,000 people on the list. So you're talking maybe 20 people at most found a marrow donor. So, the other 1,980 people in search of a donor did not have good outcomes. And so it was 1% for African Americans back then and 23% for Caucasians. And now it's in 2021, it's 23% for African Americans, and it's 77% for whites. So it's still a big need for donors. So I just want to put that out there, and we have to close that gap. So I started doing bone marrow drives. I was told that no one had found a donor, and to use my energy. They have found their own donor, but probably the best course would be to use my energy to just be stronger for my treatment. And I also asked the doctor if diet and exercise would help, and he actually said no, and I didn't listen to that. He also said don't run any marathons. So started doing a bunch of drives, churches and the military. I did them all over the country. The military would fly me around, and also I would do civilian drives in malls and different places. And after the 1 year mark, I moved down to Atlanta, Georgia, and I had been given 3 years to live, and I moved down to Atlanta, Georgia, because my wife is from this area. In case that 3 year diagnosis was right, I wanted her to be closer to her family. So I went to this drive in Columbus, Georgia, and this is maybe 18 months into my diagnosis, and this white gentleman came, and he said, "Hey, he had hairy cell leukemia." And he said he had been going out to MD Anderson, and that MD Anderson had turned his leukemia around with some experimental treatment. He said, "Hey, these drives are great, but I also recommend that you look into this option." So, and I looked into the option. He gave me the information, and I started going out to MD Anderson. And by the way, he's doing fine. I just talked to him a few weeks ago. I always like to thank him for coming to that drive to get me, actually helped save my life because he made me aware of clinical trials. So I went out to MD Anderson, and the doctor said, "Hey, I'm going to put you on clinical trial after clinical trial." And we kept doing that. And then about the 3 year mark, I still was pretty much where I was at the 1 year mark. The various drugs would work for a while, and then they would cease to work. So I asked him if there was anything else. He said that we had one more drug, and but we're having problems in the lab, and it's probably gonna be a while. But they will give me a call when they got approval by the FDA to use it. So about 6 months later, he called and said, "Hey, we got approval." So I went back out to MD Anderson in Houston, Texas, and I became the second person to use Gleevec, and it worked. And about 6 months later, actually 9 months later, I ran a 26.2-mile marathon. So much first doctor's advice about diet and exercise. And then I cycled 111 miles for a century about 5 months later after that. And then, as was stated before, I'm the world's longest living survivor on Gleevec, which is used for so many different drugs. Gleevec is like 350,000 people on Gleevec, but there are different generations of that drug, and now it helps with other cancers. And from that drug, many other cancers such as lung cancer, breast cancer, thyroid cancer, and many more have been used, have been helped with variations of that targeted drug. So I thought that my only cure could come from a bone marrow donor, which I never found, but my cure came from a cure that was only a gleam in some researcher's eye at the time that I was diagnosed. So, and my daughter, who was 5 at the time, she grew up, and she graduated high school, went to Harvard, then went to Emory Medical School, and she's a physician herself. So it's a great outcome, but I advocate so others can have that outcome. I'm the longest living Gleevec patient, which is kind of ironic, being African American, but stars lined up that way. And I just want to pass it on, such as the doctors who have helped me, the gentleman who came to the bone marrow drive helped me, and just want to stay out there on the battlefield and close that gap. So thank you very much for having me today.
Thank you so much, Mr. Mann. I mean, what an incredible story, and thank you for sharing it with us. I think your story is very special when we consider that, when we look, as we saw the opening video, that participants in cancer treatment clinical trials, it's 8% of Black Americans. So we really need to bring awareness to the community and let people know that for precision medicine to work, and Dr. Walker is shaking her head, we need to know about these cancer phenotypes in the, in the Black community.
Well, I'm Exhibit A, so I always like to say that.
Yeah, exactly. So everyone, I respect your time. It is 1 o'clock and the webinar was scheduled for an hour. If anyone has a question, I think some of us will hang on for another couple of minutes to ask a question. Otherwise, I'd like to thank the speakers. This was really, just marvelous, just fantastic. So rich, the conversation, and so much information from 4 different areas. And I want to thank all of the attendees today. And next week, I'm going to put in a promotion for our next Wellness Wednesday, which will be next Wednesday with Dr. Lorenzo Cohen from MD Anderson. He'll be talking about comprehensive lifestyle for risk reduction. And Marcia Banks Harold will be producing a gentle yoga video to go with that. So 1 o'clock, if you need to hop off, please do so. If you have any questions, some of us will hang on for another minute or two. Just either unmute yourself and speak or put something in the chat. Kawana Rucker, from one cancer survivor to another, live strong. Way to go.
2 times here.
Congratulations.
Yeah, and I'm on a clinical trial as well.
Oh.
I'm doing mistletoe therapy with Johns Hopkins Hospital, and I know some of you probably are very familiar with that. I got a scholarship through Believe Big. So I'm 3.5 years out. I actually went to Spain to do part of my treatments, and I did some in the US until, because I heard of mistletoe therapy and I heard of ozone therapy and by high dose vitamin C and some of those things. And I think that is why I'm doing probably better than most with a triple positive breast cancer diagnosis, stage 1. And so now this is where I am. I'm a health coach now, and I'm 1 exam away from being a health practitioner and a traditional naturopath because of my journey. And this is my passion now, is to teach our community about integrative health. So my question to those here would be, clinical trials. I was not given, from I'm here in Pittsburgh. University of Pittsburgh is a major research hospital for cancer. They did not give me any information on clinical trials as a minority. So my question to, the group is, how do we make this available to when I'm coaching people now, I'm like, ask your physicians about clinical trials. But this is something that is information that should be given out, right? Just like if there's an integrative unit that's a part of your hospital, why isn't that standard of care to say, hey, we have an integrative group we want you to work with, not to prevent cancer per se, but to treat you, because we know that nutrition has such a great part in our recovery. We know that acupuncture and yoga and meditation and all these things are such great benefits to us as we try to prevent reoccurrence. So how do we get this into the hospitals? Like, I'm just trying to figure out, where is our avenue to get in the hospitals to make sure that we are making sure minorities know about clinical trials and to know that there's integrative care within their units where they can get these things, because I'm getting some of my integrative care for free now, but it wasn't because the hospital told me, it's because I made my voice known out on Instagram, and an organization here said, Kwana, we give this to the hospitals for free. They didn't tell you about this, you know? So it saddens me, because they not only do integrative care, but they do free mammograms, they do genetics and all these things. That stuff was not offered to me when I was diagnosed almost 4 years ago. So what?
Maybe I can speak on this, because I am PI. I run integrative trials for Henry Ford Hospital, well, clinical trials, I should say, for Henry Ford Hospital. I think, you know, unfortunately, we need to educate our physicians, okay, and our nurses on making sure that in an equitable, with unbiased approaches, offer people, don't look at a patient and decide, oh, well, they're probably not going to participate in a trial, because most major medical centers have it. But then a lot of people of color do not always live or are able to go to those big centers like University of Pittsburgh, like Hopkins, like Michigan, and Henry Ford and Carmano's here in the Detroit area. So they may not even have the chance, and we have to bring it to them where they are. That's something that I have a grant for right now, that I'm working with prostate cancer patients to do that. But let me tell you, as the medical director of integrative medicine at Henry Ford, it took 10 years plus to educate my colleagues in medical oncology, because they don't teach us at my when I was in medical school, it was not part of the course curriculum. This was something I educated myself about, because I was raised culturally. My family's from the Caribbean, and we use many different things to help improve our health care across the board, not just for cancer. So it was an interest of mine, and I went out there and educate yourself, and you have to be your own best advocate. If it's not being offered to you, you tell your doctor, aren't there any trials available? Go online like you did and look it up, because they are out there. We're trying to educate, and that's part of the grants we're doing here. How do we educate our physicians and make sure they're offering patients, they're thinking about it, that they're doing the genetic testing early on? Because there's data from the ASCO meeting last week showing that Black prostate cancer patients, they're not tested genetically until they've gone through 1 or 2 standard of care treatments, whereas white prostate cancer patients get it after 1 course. That makes a difference in your outcome, okay? So not all of it's on you, but we have to work together. I've done my work now. Integrative medicine is part. We have it in our new cancer center building. When you walk in the door, there is the Excite program for exercise. Integrative medicine's in the same space. So, but it took me many years to get that accomplished, and there's more to do, okay? So I'm just saying, I understand, I hear what you're saying, Ms. Rutgers. I'm doing my end, you have to do yours, and that's where coaching and advocacy comes in.
And also from the patient point of view, and sometimes that I do in my advocacy, is that, and I advocate with the Leukemia Team in Training, Be the Match, and some other organizations, is that we go out and we spread information about clinical trials even before you are even close to a diagnosis of any disease, so that you become aware and know what a clinical trial is. And Leukemia and Lymphoma Society they have a clinical trial center where that everybody who's diagnosed with leukemia can call from early in the morning to late at night. They're manned by oncology nurses, and they can get a list of what trials are being offered and that fit with that person, because each person has a different set of circumstances with insurance and so forth. And they can take that list back to their doctor, so that the patient doesn't have to go through all this trying to understand about clinical trials. A group of people are doing that for them. And as I stated in my example, I was 18 months into my diagnosis, or this other guy was diagnosed about 6 months. He had been through clinical trials and his leukemia was turned around. Here I am 18 months later, just getting started.
Wow.
So that's part of my advocacy, and going out into the churches and just speaking to groups so that that's made known. And as was stated before, bring clinical trials closer to the patient, that he doesn't have to go out to MD Edison and spend all this money on airfare, on hotels, on parking, on childcare, and so forth. Close that to make it easier for the patient. And those are some of the other things. And then the bias that was talked about, let's not assume that this patient may not be interested in a clinical trial. Ask anyway, ask all the time. That should be one of the initial options, not just, okay, standard treatment, bone marrow transplant, and no mention of a clinical trial, but all those things up front. And then, as stated before, the patient has to be their own advocate and do their own research also.
Thank you. Thank you, Kawana, for the question. Really, really important. Really important questions you bring up. I think just I'm a yoga therapist, and there were actually three other yoga therapists were on the call earlier. And part of our frustration is, and we all are associated with hospitals, is how can more of us get into the hospital system to provide care? And we're from the clinician end, we're trying to get in, and we're not that successful, to be honest with you. So I appreciate Dr. Walker and Mr. Mann and the feedback. And I've kept you all now 11 minutes past your lunchtime. Thank you so much. I mean, this was really, really very valuable, very important conversation. So with that, we will wrap up and have a wonderful day. Okay, bye.